So good evening, everyone. My name is Monita Sundar. I'm the program coordinator for Prostate Cancer Supportive Care Program. Tonight joining me is Dr. Ed Chedgy. He's the Urology Fellow at the Prostate Clinic here. And we also have Dr. Ben Mass, who is a Radiation Oncology Fellow from the BC Cancer Agency. So from the physicians and the staff of the Vancouver Prostate Center and the BC Cancer Agency, I'd like to welcome you tonight to this evening's session. Support for this program has been provided from a number of different organizations. I would like to acknowledge the Special Services Committee, the BC Ministry of Health, and Prostate Cancer Foundation in BC, as well as philanthropic donors. We also are the recipient of a number of research initiative grants, such as the November Michael Smith Foundation and Prostate Cancer Canada. So the Prostate Cancer Supportive Care Program is designed to provide support care for both patients and their partners from the time of diagnosis. This is both a supportive care program and a research initiative. We use a modular approach, and our program provides supportive care beyond treating the cancer itself. Most modules in the program include preemptive and educational themes, and patients can just choose whichever module that they are interested in. We believe that knowledge is empowering, and education sessions can help answer questions and relieve stress. So the PCSC program is currently comprised of 6 modules. Tonight is the first of 6, Introduction to Prostate Cancer and Primary Treatment Options. There are 5 different modules. The second module is Managing the Impact of Prostate Cancer Treatments on Sexual Function and Intimacy. We have a lifestyle module component, and that is comprised of nutrition and exercise. We also have recognition and management of treatment-related side effects of androgen deprivation therapy. Our 5th module is pelvic floor physiotherapy for urinary incontinence, and our 6th module is counseling services and group therapy workshops. So just to give you a bit of overview, this evening's presentation will cover the following. So you'll get an anatomy of the prostate and a prostate cancer 101, strategies for managing the disease. And then later this evening, we're going to have individual discussions with the urologist and radiation oncologist. You'll have about 8 to 10 minutes to answer any questions that you may have that concerns your prostate cancer. And as that is happening, I will continue on with other parts of our program and what we offer. So anything that you do miss, I'll be able to go over that, and you also have it in your handout. So with that said, I'd like to introduce Dr. Ed Chedgy.
So what we're going to try and cover is what is the prostate. This is probably something you haven't really thought a huge amount about until now. What does it do? What is PSA and what does it mean? And also talk about prostate cancer itself and how we classify it to help guide us in guiding you as to what the best treatment options might be for you. So the prostate gland is a male sex organ. It sits deep in the pelvis, so you can see it here on the slide. It's below the bladder here, behind the pubic bone in front of the rectum, so obviously we do a DRE to feel the prostate, and it surrounds the urethra, so the urethra is the tube through which you pee. What do we know about prostate cancer? We know it's a very common disease. For most men it's a slow-growing disease and doesn't necessarily cause a problem, and for those men they'll often die of something else and just die with prostate cancer. But our job is to identify those men that prostate cancer is going to be a problem and try and help and counsel them as to what the best options for them are. We know that there are certain risk factors for prostate cancer, that as you get older there's an increased incidence of prostate cancer. That black men compared to white men have a higher risk, and again white men compared to Asian men have a higher risk of prostate cancer. There's also evidence of family history, in particular sort of looking at the BRCA type mutations that are similar to breast and ovarian cancer, so you may have been asked about that. And with respect to diet and obesity, there is some evidence about the correlation between that and prostate cancer, but at this stage it's not something that's concrete, so there's still some question marks about that. So what do we know? That by the age of 70, about 1 or 2 black men have prostate cancer, about 1 in 3 white men have prostate cancer, and 1 in 5 Asian men have prostate cancer. So we understand that as the risk. But actually for the vast majority of them, we don't even find it, we don't know about it, and it doesn't cause any symptoms. And They'll often die of something else, and it's just from autopsy studies we've got this data to say, okay, we've done an autopsy and actually this guy had prostate cancer, but he died totally of something else. And then we come to the PSA. So what is PSA? It's a test that you've probably all heard a lot about, and basically it stands for prostate-specific antigen. So it's a protein that the prostate makes, and it's secreted in your ejaculatory fluid. And essentially its job is to liquefy your ejaculation so that it can do what it needs to do. And we measure levels in the blood to see, what your levels are, and that along with a digital rectal examination helps us to determine, if there is a risk of prostate cancer or not. And the good things about PSA testing is that, because we have a test, we can now diagnose prostate cancer earlier. Back in the 80s, or before then, before we had the test, a lot of men would present with metastatic disease, so disease spread well beyond the prostate, by which time there was no curative option. But now obviously PSA testing highlights that we can find the cancer earlier and treat those that need treating. So it is an effective test as well for men once they've got prostate cancer for determining how they're responding to treatment. So once you've got cancer, if we treat you, the changes in your PSA, depending on what kind of treatment you have, will help guide us into knowing how well you're responding to whichever treatment it is. And you'll regularly have PSA as part of your follow-up, even regardless of which treatment option you were to choose. The problem, just going back a bit, the problem with PSA testing is it's not prostate cancer specific. So you read a lot in the press about PSA is rubbish, you shouldn't have it, it's not very helpful, it means you end up with treatment you don't need. And I think in the past urologists have been guilty of sort of acting on PSAs, finding low-grade cancer and being quick to remove prostates, which actually now we know we don't need to do. And so you can also have a PSA that's very high and we don't find prostate cancer, and a PSA that's very low and we don't find prostate cancer. So that's where some of the controversy lies. But I think for everyone here who's been diagnosed with a prostate cancer, it's actually very helpful now going forward as to working out how you respond to treatment. So once we've diagnosed the prostate cancer, we need to help stratify it into a way in which we can guide you as to the best way to manage it. And we do this by two things. One is called the stage, so how extensive the tumour is, and the other is the grade or the Gleason scoring system. So when we look under the microscope, how aggressive do the cells look? Is this a cancer that is going to behave itself or one that's not going to behave itself? And that will help us guide you as to what we would recommend as the better treatment options. So when we look at the tumour stage, that looks at the commonest system we use is called the TNM system, and it looks at the tumour stage, so how far it's spread beyond the prostate, whether there's any evidence of lymph node involvement or whether it's spread well beyond to include metastases to other organs or bone. So we stage the T stage, T1, 2, 3 and 4. So T1 prostate cancer is the cancer that we detect, but we can't feel anything when we examine the prostate. Okay? A T2 prostate cancer is we can feel something in the prostate, but it feels confined to the prostate. A T3 cancer is one that's spread just beyond the prostate, either into these seminal vesicles here or just before you get to them. And a T4 is sort of spreading out into the bladder neck and into the pelvic sidewall, so again, further extensive than others. And we can subclassify those into T1, A, B, and C, T2, A, B, and C, T3, A, and B, and T4. And so T1, A, and B are basically, as men get older, they often get lower urinary tract symptoms. And one of the operations we do for that is called a TURP, where we shave away some of the prostate to open up that channel. And if we find prostate cancer in the resection, in that case, then you'll either be a T1A if it's less than 5% of the chips, or T1B if it's more than 5%. The vast majority of men, we probably see a T1C, so they have a high PSA as part of an annual screen by the GP. They go on to have a biopsy, and we can't feel anything, but the biopsy shows a cancer. Looking at T2, this is clinical T2 is what we find when we feel a lump in the prostate. And T2A is 1/2 or less than one side, so a quarter of the prostate. T2B is more than 1/2 of one side, so half a prostate, and T2C affects both sides. T3, this is where, as I said, the prostate cancer is spread just beyond the margin of the prostate, and so T3A is just outside the prostate but not into the seminal vesicles which sit behind the prostate, and T3B is evidence that it's spread into those seminal vesicles. And T4, as I said, is spread into the bladder neck or the pelvic sidewalls, and tends to be not a localized cancer that is treatable with curative intent. So that's the staging system. So we also, there's sub-classifications for the nodes and looking at other areas. We won't go into that in too much detail. Now we look at the grade, and the grade is essentially what the cells look like under the microscope. And it was named after this guy, Dr. Gleason. And essentially what the pathologist does with the biopsy specimens, he'll look at the biopsy and he'll look at what the cell types look like and give it a score between 3 and 5. Okay, 1 and 2 were historic, and we've kind of got rid of those these days, and now we sort of grade it between 3 and 5. And what that means is a Gleason grade of 3 is if the cell looks more like a normal prostate cell, and 4 is less like a normal prostate cell, and 5 is a very aggressive cell that's way different from the normal prostate cell. And that gives the 1 score. And we then look at, when they look down the microscope and they see if it's all 3, then they would call it a 3 plus 3. If it was majority 3 but some area of 4, then they would say, well, the commonest type is 3, so we call it a 3, but there is some 4, so 3 plus 4, if that makes sense. So if you can have a 7, which is a 3, if most of it's 3 and then some of it's 4, then that's better than having a 7 that is majority 4 with a small amount of 3, because you have more of the aggressive cells than the less aggressive cells. Does that make sense? And so that gives us an idea of how likely this cancer is to divide and cause problems further down the line. And then this is just a slide to show you that 1 and 2 look like very rounded, normal cells. 3, 4, and 5, you can see the cells the architecture looks more aggressive. There's less uniformity in them. And you're losing some of that circular glandular structure which normal prostate cells have. And so that becomes, as you go down the slide, things are getting more aggressive. And again, just hammers home the point that the differences between a 3 plus 4 or a 4 plus 3, that there are slightly nuanced differences between the two. So other things, if you've had a biopsy that we can take into account when assessing the aggressiveness of your disease is, how many cores are positive. Most biopsies are anywhere between 8 and 12 cores, depending on the size of your prostate. And if more cores are positive, then that suggests you have a higher volume of disease than, say, if just 1 core is positive. We can also look at the length of the core to get an idea of, if it's just a 1 millimeter focus, that's not very much, but if it's the whole core of, 10 millimeters, that tells us there's a bigger tumor within the prostate. And also we can then look at, where in the prostate the positive cores are. So sometimes it can just be one area, sometimes it could be multifocal. And, for us as surgeons, certainly that helps guide us into terms of making decisions about nerve sparing and that kind of thing. So based on all that information, and your PSA, we can now sort of come up with a plan to risk stratify you to help guide us in decision making. And so the commonest risk stratification we use is what's called the D'Amico stratification. So a low-risk prostate cancer would be anyone with a PSA less than 10, with a Gleason score of 6 and a clinical stage T1 to T2B. So less than 1/2 of one lobe of the prostate, Gleason 6, so less aggressive cells, and a PSA less than 10. And the most common treatment option we would recommend for that would be active surveillance, but in certain circumstances, prostatectomy, external beam radiotherapy and brachytherapy could be considered. And I'd say that for most of the slides, the treatment options list is not necessarily in any order of preference, they're just the options. For intermediate risk, you could have any of the low risk, but if any one of those puts you into the intermediate risk, you automatically go up to intermediate. So you could have a PSA of 8, a Gleason score of 7 and a T1, but that would put you up into the intermediate. So this is for men with a PSA of 10 to 20, a Gleason score of 7, or clinical stage T2C. And this kind of group, on the whole, we would tend to steer more towards active treatment, either in the form of surgery or radiation. But for some select men, surveillance could be an option. And then we look at the high-grade prostate cancer. So this is for men with a Gleason score of more than 20. A PSA of more than 20, a Gleason score of between 8 and 10, and a clinical stage T3 or 4. So if any one of those factors is present, then that would put you into the high-risk group. And again, we would again think about more active treatment options in order to aim for cure. The other thing about the prostate cancer, it needs to be localized. So it needs to be just within the prostate, and if it is, then it's potentially treatable and potentially curable. And the other thing to say is prostate cancer is not like other cancers. You do often have time to decide which treatment option is best for you. And again, that timing will depend on your risk stratification. So there is time to think about what suits you best and what best fits in with your ideas about treatment. So we're going to come on to talk about treatment now. So I'm going to talk about active surveillance and radical prostatectomy, and then Ben will come and talk about the radiation options. So active surveillance. So what this means is, we've diagnosed you with a low-risk prostate cancer usually, and we're saying, well, the chances of this becoming a problem is small, so let's just keep an eye on it. It doesn't mean we say you've got nothing, go away. We keep an eye on things. We get regular PSA tests and regular digital rectal examinations. And essentially it's for men who have a low-risk cancer that we think is unlikely to reduce your life expectancy. Or we may feel that there are other health problems that are going to become more of a problem, and we can say, well, let's just keep this on the back burner and keep an eye on things. If things change, we can readdress it. And the idea is that we don't treat a prostate cancer that doesn't necessarily need treating, and you can then avoid some of the side effects of treatment and the risks of treatment that come with that. And also the patient has to want it. You can't just say you're having active surveillance. If you want something else, then we talk about that. So what does it mean? We do regular checkups with digital rectal examinations. We repeat your PSA every 3 to 6 months. And we usually repeat the biopsy within 18 months, and that depends on what we found on the biopsy and things. And then tends to be every 2 to 4 years after that, depending on your PSA and how much cancer we found. These days we would usually recommend an MRI at some stage if you're going to go down the route of active surveillance. And the idea of an MRI is, although we've got the biopsy, it's not exact. And the MRI can potentially highlight areas within the prostate that may be harboring a more aggressive cancer that we haven't got on the biopsy. So you can see on this slide, on the left hand side of the picture, the sort of the U-shaped white area here is normal prostate tissue. And if we look on the right side, on the left side of the slide it looks okay, but here on the right side it's a lot darker. And that would suggest an area of prostate cancer that we would want to try and aim a biopsy to make sure there's nothing more sinister than Gleason 6. And we have now techniques available here to do that called a fusion biopsy, where we fuse the ultrasound picture with the MRI so we can localize that more specifically and get more information. If you're on active surveillance, you're having all these tests, you're having all these biopsies, what would be the trigger for us to say, okay, well, we need to change gears and start thinking about treatment? Usually this would be a rapidly rising PSA or a change in the prostate examination, which would then trigger a rebiopsy, and if we find more cancer or of a higher volume or a higher grade, then we would recommend treatment. And again, suspicious finding on MRI, we can often say, okay, well, your biopsy says this, but your MRI says this, the chances are you have something more aggressive, we can go down the route of surgery. And for some, or radiation therapy, and for some men, they just don't like the idea of continually being followed up, and they say, enough is enough, I want something doing. That's pretty rare, but that does happen. So that's active surveillance. So now come on to talk about surgery, so radical prostatectomy. So again, this means surgical removal of the prostate, and we normally take the lymph node tissue at the same time to assess that for any evidence of microscopic disease. And this is for men with any risk disease, so low, intermediate or high, who have a prostate cancer that is confined to the prostate, or T3, but no more than T3. So it can, clinically, if we think it's gone to the seminal vesicles, we can still offer a prostatectomy. But no evidence of spread anywhere else, so no spread to the lymph nodes or to bone. And obviously the patient has to be fit for an anaesthetic to undergo surgery and want to have surgery as their treatment of choice. If that is something you decide, the things you can expect is to meet with an anaesthesiologist before the operation to go through their side of things. We have some research programs here, one looking at having an MRI before surgery, and the idea of the research is to compare, okay, the MRI says this, and now we have the prostate which shows cancer here, here and here. You know, did the MRI pick up all the cancer? So how good a test is an MRI at predicting what is in the prostate? There's also a sort of supervised exercise program, which is basically a free personal trainer to get you fit and ready for surgery. And there's also another research study that's relatively new, looking at the some of the sexual effects of surgery, and looking at being mindful and trying to overcome them as a kind of couple and getting through it. You'll also have regular blood work, ECG and a chest x-ray if the anesthesiologist thinks it's necessary. Most operations here are done at the VGH or UBC, and if you have your surgery at VGH, you'll have a short post-operative stay, usually on the 4th floor, which is our urology ward, in the Jim Patterson Pavilion. Usually patients only stay one night, so it's you don't get to hang around too often with any of that. So the surgery can be done either as an open operation, so the small cut below the belly button, or laparoscopic or robotic surgery. So here we offer, at VGH, we offer open surgery and robotic surgery. The things that are in common between the two is general anaesthetic, so you'll be put to sleep for both kinds of procedure. We can do nerve sparing with either of the procedures if your tumour characteristics allow us to. So if a prostate cancer is very aggressive and is at the external margin, or the wide margin of the prostate, then often we say we shouldn't do a nerve spare because it could potentially compromise the cancer side of the operation. But if your cancer is more of an intermediate risk and the cancer is more in the middle of the prostate rather than the sides, then sometimes we leave a bit of the tissue at the sides of the edges of the prostate, so not the prostate itself, which have the nerves that supply signals for erection. So that's what a nerve spare means, and we can talk about that individually afterwards if that's something you have more questions about. So these are the a schematic of the two incisions. They're both slightly incorrect because the surgical incision is often a lot smaller than is depicted here. And with the Da Vinci, you have 6 different holes. So actually, probably when you add the two up, they're roughly equal in terms of total length of incisions. But with the robotics, it's smaller holes, and with the open, it's one bigger hole. What to expect? You normally come in on the morning of surgery. Surgery takes 2 to 3 hours. You're in hospital for a day, sometimes 2, especially if you've had to travel from far away. Most patients tolerate the pain just on Advil and Tylenol, don't really need a huge amount more than that. Where we remove the prostate, we join the bladder back onto the urethra. So this picture again is slightly wrong because the prostate, you'll see, is still there, but after surgery that will be gone. And this part, the bladder neck is joined onto the urethra, and we leave a catheter in to allow that joint to heal. So to drain all the urine away, to keep any pressure off the anastomosis, and allow that to heal. Normally it's in for about a week, sometimes 2 weeks, depending on how well the surgery has gone and if there are any issues. We then get the catheter out, which is fairly straightforward, and check your wounds and make sure everything's okay about a week or so later. Depending on what kind of work you do, you normally need 3 to 6 weeks off work. You shouldn't really do any heavy lifting for about 6 weeks just to allow all the incisions to heal. But as I say, most men tolerate it pretty well. The advantages of prostatectomy over other treatment options are it's pretty well tolerated. Very few patients have major complications. At the same time as removing the prostate, we can also remove the lymph nodes and see is there any evidence of disease in the lymph nodes that we haven't detected on any scans or anything like that. And also the pathologist gets the whole prostate, so they can look at the prostate, slice it up into little pieces, and look at exactly what's going on in the prostate and give you a better idea of whatever you have, whether it's good or bad. We can tell you this is what we found, and we can recommend other things if necessary afterwards. And also, it's in the bucket, it's gone, the cancer's out. That's for some men is a great psychological relief. And one of the buy one get one free options with surgery is that as men get older, we've already talked about, they can have benign growth of the prostate, which causes them to get up at night to pee, to find that their stream isn't as good as it used to be. And one of the benefits is by removing your prostate, some of those side effects can be treated as well. We know that there's high cure rates with surgery and excellent long-term results. If we find that the cancer is more aggressive than initially thought, with evidence of potential cancer left behind, we can then come in with radiation therapy to supplement the treatment of the prostate cancer. The same isn't necessarily true the other way around. Okay, and as I said, it's very well tolerated with a low risk of life-threatening complications. But as with any surgical operation or major surgery, there are risks involved with it, and there are side effects. And the main side effects with prostatectomy are the risks of urinary leakage, so incontinence, and it tends to be stress urinary incontinence. So if you strain, cough, sneeze, then you can dribble a small amount of urine, as well as erectile dysfunction. So we know that, as we talked about, the nerves that supply erections come down either side of the prostate. They can be damaged as part of the surgery and can result in problems with getting spontaneous erections. So just to put a few figures on this, we know that anywhere between 50 and 90% of men can have issues with erections post-operatively. But if immediately after surgery there's an issue, up to a year, or even now evidence suggests 2 to 3 years down the line, men can still recover function. And there are things we can do to help. So there's injections and pumps, and there's a whole module about how to deal with the sexual side effects of treating prostate cancer. So things may be different, but again, we can help with that. With respect to urinary incontinence, by about a year, the vast majority of men will have some leakage to begin with as soon as the catheter comes out. By about 6 months to a year, about 75% of patients have recovered so that they only just wear one little pad for safety during the day. And by about a year, about 90 to 95% of patients have recovered, what we call social continence. So they may just wear a pad just for safety because they're worried, but tend to not really need it. And only about 1 to 10% of men will end up needing a blood transfusion. About less than 1% of men will have severe incontinence, such that they're flooding 20, 30 diapers a day, and they'll need to go and have a further operation to help with that. But, and it's a fairly straightforward operation, not like the prostatectomy sort of daycare surgery. Another thing is where we join the bladder onto the urethra, that can scar down in about 1 to 3% of men, but again, that's pretty rare. And if that does happen, we just stretch things up again and can help you with that. And very occasionally, we know that the rectum and the prostate are very close together, and very, very occasionally, there's a chance of making a small hole in the rectum by removing the prostate. But again, that's very rare, so I can't remember the last time I saw that happen. Then they come on to talk about, the robotics versus open. I mean, this is the robot, so the surgeon sits at the console, and the robot, which obviously there's no patient in this picture, but the robotic arms are connected to the patient via small keyhole ports, and the surgeon controls the robot to help remove the prostate. And basically allows 3D visualization deep down in the pelvis and up close that you don't necessarily get just by looking at your eyes with your eyes. And the great thing about it compared to laparoscopic surgery is the instruments are wristed, so you've got full 360-degree motion, which helps with the surgery. And this is kind of what it looks like. These are the arms that you can see are wristed, and the controller, that's sort of the surgeon's hands in the joysticks to help control the robot. And that's surgery and active surveillance.
So I'm from the Cancer Agency, which is actually down the street, and the Cancer Agency provides radiation treatments and chemotherapy and other treatments for all different cancers. Prostate cancer is an interesting cancer in that some cancers really need have to have surgery up front to remove the tumor. But for localized prostate cancer, there are curative treatment options that don't involve removing the prostate gland, and I'm going to talk about 2 of those. One of them is brachytherapy, and the other one is external beam X-ray radiation treatments that can cure the disease and treat it without surgically removing it. Just to clarify, you might also hear about adjuvant radiation, which we're not going to talk about today, but that's after you've had surgery, if the PSA rises or the cancer comes back, or if there's positive margins after surgery. Sometimes people get radiation to sort of sterilize the area where the surgery was. So sometimes people are in the situation where they're getting radiation after prostatectomy. But these 2 treatment options I'm going to talk about are for people instead of surgery, choosing to go this route. So I'll talk about what prostate cancers are appropriate for these and what these procedures are like. So the first one is brachytherapy, and this is a form of giving radiation to the prostate gland by putting these small radioactive seeds in it with needles. And we plan where to put the seeds and where they give off the radiation on the computer system, and these stay in the prostate gland and treat the cancer that way, so without removing the gland. So where is brachytherapy offered in BC? At the cancer agency. So there's one in Vancouver, just a couple blocks away. There's one in Abbotsford, Victoria, and Kelowna, where they can have these procedures done. To do that, you have to have a consultation with the radiation oncologist at one of these sites first. And now we learned about the different tiers, like the low risk, intermediate risk, and high risk. There's different packages of radiation that are best for each person's situation. So you have to figure out where you fall. For low and intermediate risk cancers, often we can use just brachytherapy seeds alone to treat the cancer. If it's one of those that falls in the high risk category, for whatever other reason, we often combine it with other treatments, sometimes hormone treatments and X-ray treatments, for if people fall into that high risk category. So it's not always an option to just have the brachytherapy, but I'll talk about what that's like. So a good candidate for brachytherapy, usually less than 75 or 80 and having good health. That's because you need to be put to sleep for the procedure usually. And the prostate gland can't be too large, because some men's prostate glands, we can't fit enough of those seeds into them to give enough radiation. So we have to do a test to see to make sure it's the right size. And sometimes we can use hormones to shrink the gland. If people really want to have this treatment and it is a bit too big, we can sometimes shrink the prostate first by going on hormone treatments. And another thing is, we want patients to have pretty good urinary flow before this treatment, and I'm going to explain why. Is that, sometimes these symptoms get worse from the swelling of this procedure. So if people already have bad urinary function, meaning having to pee often at night, getting up more often, those things will get worse. So if you're starting off at a swollen prostate to begin with, it might not be the best choice. And some people sort of patient preference, what kind of treatment they're most looking for. So this is a cartoon of how we do the treatment. So this is an ultrasound probe to make sure we're putting the seeds in the right spot. Same way you've had your biopsy, where they took the biopsy through the wall of the rectum into the prostate. Here we actually go through the skin of the perineum, and the needles go right in, but this ultrasound probe lets us know that we're putting the needles in just the right spot. This is another picture of that. So there's multiple needles. We just do one at a time, and eventually leaving it behind all the radioactive seeds, which stay in place. So yeah, you have to see an oncologist and an anesthetist to be set up for this procedure. We do an ultrasound to measure the prostate gland and plan exactly where we would put the seeds. And about 3 weeks after that, we order the radioactive seeds from the provider, and they arrive and they're sterile, and then we do the procedure at the cancer center. After you've had the implant, patients are seen roughly every 6 months, and we check the PSA test and follow the PSA going down after the treatment. So what are the advantages of this choice of treatment? It's a day procedure, it takes about an hour. It can be done under general, sometimes a spinal anesthetic. You go home 2 to 3 hours afterwards. You don't go home with a catheter in. And there's a fairly quick recovery. We haven't made any cuts. Your prostate hasn't been removed. We haven't reattached the urethra, so there's not as many limitations on your initial sort of healing period as there would be after a prostatectomy. Some other advantages, most studies have shown that sexual function, like retaining erections, is likely a bit higher in brachytherapy alone, if that's an option for you, than in surgery, and the excellent control of the PSA and cure of the cancer. And also, another advantage is you're less likely to have the sort of urinary incontinence of leaking urine and needing pads in the long run, but you have a different set of urinary problems that come with brachytherapy. So there are side effects from this. But we don't have to redo the plumbing, but you cause a lot of swelling of the prostate gland when those seeds are put in and when they're treating the cancer. So a swollen prostate gland doesn't cause incontinence, it causes blockage of the urine. So men who have swelling in the prostate, sometimes they can't pass their urine and their bladder gets full, and it's a very uncomfortable sensation. So if, unfortunately, you get a lot of swelling, sometimes people even need to go into the hospital and get a catheter put in because they can't pee. But at the very least, most men have irritative symptoms in that period when the treatment's working. So certainly it irritates the bladder, causes swelling there in the prostate. So you're going to get up more often at night to pee. Sort of generally the stream will be slower. things like that. So it is bothersome. And about 5% of people end up needing a catheter during that period if they have swelling. And usually it's people who have worse flow of urine beforehand because their prostate's already a bit swollen or larger. The other thing that can happen is it can irritate the bowel right behind the prostate, like where we had the ultrasound probe and where you got your biopsy. So that part of the rectum right there can get some swelling and irritation. And then, so after the swelling, things sort of heal and fibrose and becomes more scarred than they would have been. And that scarring can lead to sort of long-term problems. So that wall of the rectum might be a bit thinner, more friable. You can have a little bit of bleeding occasionally in your bowel movements. It's just because the tissue there is thinner. And a rare risk of like a 1 in 500 of a more serious bowel problem, like a fistula or ulcer that doesn't heal. So even though it's arguably less likely to cause erectile dysfunction, at least initially, than the surgery, the sexual function does decline over time in men after they've had brachytherapy or the other radiation treatments. You know, we cause swelling there, we cause sort of scarring afterwards. But among younger patients, so people in their 60s who have quite good erectile function before treatment, about an 80% chance of still having sexual function 5 years later. These numbers aren't as good for people who start off older and with worse erectile function. So, you know, there's no guarantees, but generally people can do quite well. Sometimes people take Viagra during the period after and need other sort of sexual aids as well. So some other facts about it. The number of seeds that we put in are between 70 and 150, depending on how big the gland is, how the plan works. The half-life is about 60 days, so these stay there, but they lose their radioactivity over time, and eventually they become inert. So they're still like little seeds, but they're not doing anything. They are in your body permanently, though. During the first 6 months, you would set off the radiation detectors at the border. It's fine, you have a card, but you have to let them know. But then after that, you wouldn't. And you're not, the radiation is very low once it gets a small distance away from you, so you're not a risk to your partners or family and people that you're around. There's no limitations on what you can do safely. So that was the low dose rate brachytherapy. Now, if you're researching prostate cancer treatments, there is something called high dose rate brachytherapy. It's a different way of doing the procedure without leaving those seeds behind, but it's actually not very common in British Columbia. It's more common in some other provinces and in the States. So if you're researching different routes, it's basically just as effective and very similar side effects. The only place in BC that's offering this currently in the high dose rate is Kelowna. So there's 1 or 2 doctors there who do the high dose rate instead of the low dose rate. Essentially, as far as we know, it's equally effective as the permanent seed implants, and just offered in Kelowna right now. So that was the seed treatment. Now I'm going to talk about the X-ray treatment, the external beam radiation treatment. So sometimes, based on the cancer or the patient, this is a better option. So almost all prostate cancer patients could choose the X-ray external beam radiation, low, intermediate, or high risks. But as we said, you know, low risks usually go to active surveillance, intermediate, and people on the very high risk spectrum, we usually do offer some of this X-ray treatment as well. But it really varies on the package of treatment once you see your oncologist. It has been shown that brachytherapy gets a little bit more radiation dose into the tumor. So sometimes we do see better long-term outcomes with brachytherapy. So sometimes now we are combining some X-ray treatment and a smaller number of brachytherapy seeds as well, if your oncologist wants to boost the dose. So like I said, yeah, that you could, and also, so I talked about adding in the seeds, but we can also add in hormone treatment. So sometimes X-ray radiation is given while you're getting shots that lower the testosterone, and that also treats prostate cancer. So sometimes it's given as part of a bigger, more aggressive package of treatment. Sometimes it's given just by itself, just X-ray treatment. So who is it not best for? Probably not someone who has inflammatory bowel disease, because it can irritate the bowel a bit. If you've had previous radiation or previous extensive pelvic surgery, sometimes there's some concerns about whether this is the best type of treatment. Again, it's only offered at the cancer agencies throughout BC, but all of the sites can do it. And to set someone up for this type of treatment, we need to do a CT scan. of your body, and we use that to aim the X-rays at you. And this is actually the cartoon of the X-ray machine. So this is a CT scanner. It looks like it's just a large CT scanner, but we use higher dose X-rays, and this can move around the patient and aim the radiation just where we need it. Now, radiation treatment this way, you're never put to sleep, you never get a needle, you never have a scalpel, so this is the least invasive, but it takes the longest. It's probably the most inconvenient in our traditional form. So the way we do it, we can't give all the radiation in one setting, like with brachytherapy. You have to come daily, Monday to Friday. Sometimes we do as many as 38, 39 treatments, which is basically 2 months of coming every day for the treatment. Now, you're only at the cancer center about 30, 45 minutes. Most of the time you wait your turn, you get set up, we may take some pictures that you're in just the right spot on the machine, and then the machine treats you, you don't feel anything, it's just like an X-ray, and you go about your day, so people can continue to work, they can continue to go golfing in the afternoon if they're retired, but you have to come every day. We can't take breaks, you can't take a holiday midway through. And this is a little bit dated. Now we can do it in about 20 treatments. It depends, so that would be 1 month of daily treatments. Sometimes it's as many as 2 months of daily treatments. So we do a CT scan every day to make sure you're in the right spot. We aim the radiation very carefully, so we just treat where we need to. This is a picture, this is a CT scan of the pelvis, and this is the prostate gland here. And this red shows where we're giving the radiation dose, the high radiation dose needed to treat the cancer. This blue is actually your rectum. So the back wall of the rectum where you had the biopsy through gets swelling and irritation from the radiation. And probably external beam radiation will give a little bit more dose to the rectum than the brachytherapy seeds, which are just sitting in the prostate. So the side effects from this, which we'll talk about, will include a bit more irritation of the rectum and changes in sort of bowel function as you go through the treatment. And this also shows that surgeons can sometimes take out lymph nodes if it's a more high-risk cancer. And we can also treat the lymph node areas just above the prostate and to the sides if it's a more high-risk cancer, but it really depends on the details of the patient's cancer. So what are the advantages of getting the X-ray treatment? Well, it's outpatient treatment. You're not put to sleep. There's no scalpels or recovery time with that. There's generally less urinary side effects than the brachytherapy and the surgery, less changes in your urine function, but there are some. But there's more irritation of the rectum that I was talking about. And another advantage, you can continue to work during the treatment, things like that. The first 2 to 3 weeks, there's almost no swelling, so you just don't feel much. And as you go through whether it's 1 month or 2 months of treatment, the swelling builds up, so you do get more side effects. So you can get some fatigue and tiredness from going through these treatments. The bowel symptoms are usually sort of increased frequency of bowel movements, so you might be going a couple times a day, sometimes loose stools or diarrhea. Usually it's fairly mild and easily managed. You'll see a doctor once a week and we can control it with Imodium or other treatments if it's necessary. And then the bowel side effects and fatigue settle. It can take about 4 to 6 weeks after treatment for it to go back to less sort of the swelling to settle down and these side effects to settle. So after the swelling, like I said, you can get some scarring or fibrosis of the area that was treated, so that leads to the later side effects that happen in the months to years afterwards, and these can be permanent changes. So one of the permanent changes, unfortunately, it can affect the nerves that lead to erection, so generally this isn't going to help, like it goes down after having a treatment like this. Bladder complications, you might not go back to exactly as the same level of urinary function you had before. So people still might be going a little bit more often, getting up more times at night, generally less so than with brachytherapy, but it will affect that. And there is a risk of rectal bleeding, like I said, from the sort of fibrosis of that part of the rectum. There's a chance of spotting and blood in the stools occasionally. About 10 to 15 out of 100 people might have that.
So we're going to continue with the overview of the rest of the prostate cancer supportive care program. What happens with cancer reoccurrence, clinical trials, and further resources that are available. So as I mentioned, tonight is the first of 6 modules. The second module is called Managing the Impact of Prostate Cancer Treatments on Sexual Function and Intimacy. This is a preemptive education session about sexual side effects of treatments and options for dealing with them, including options beyond standard ED treatments. So just to give you a little background, we do know that irrespective of whatever treatment you have, whether it's radiation, therapy, or surgery, there will be a change to your sexual function. To what degree, we don't know. It all depends on a lot of different factors such as age, your current function right now, if the nerves are spared, but even if the nerves are spared, there still is going to be a change. And Christine Zarowski, who is our sexual health nurse, does an excellent information session and talks about all the options that are available if you're experiencing erectile dysfunction or low libido. So for those of you who don't have partners or aren't sexually active with your partners, it's not just about having sexual intercourse, it's also about penile rehabilitation. And by that I mean making sure that you're getting enough good blood flow into the penis and keeping the penile tissue healthy. And so Christine will talk about other options such as Viagra or Cialis, but most patients will likely have to use other treatments. So there's things such as the vacuum pump, penile injections, or other alternatives as well. So she does a 90-minute information session and talks about what those options are and about intimacy as well. So I strongly urge patients and their partners to come to this session, irrespective of whatever treatment you're going to have. And I do suggest you come to the session before you have your treatment so you can have any questions answered by Christine. So this is a session that's available to both patients and their partners. The session is offered monthly. If you'd like to come to the session, just let me know and I can enroll you into that session if I haven't done that already. She also has an intimacy workshop that's available for couples. The criteria is that you have seen Christine in clinic and you do have a partner. So your partner has to come to the intimacy workshop, and the workshops are every 3 months. I should also add, so in addition to the education sessions, you can also see Christine in clinic. And so what she does in clinic is she will sit with you and your partner and talk about where you are at in terms of function and what she can offer you privately. So the group session is an education session. It's very informal. It's really meant to give you all the basic information so that when you do see her in clinic, you optimize your clinic appointment with her one-on-one. Okay? So lifestyle management is our third module, and as I mentioned earlier, it does branch out into 2 different themes. The first is nutrition. So it's called Nutrition Advice for Prostate Cancer Patients. This is an education session that is held every 3 months by Sherry Van Patten, who is a registered dietitian from the BC Cancer Agency. So she does a great presentation about what types of foods you should be eating specific to a prostate cancer patient, and making sure that you're not over supplementing or under supplementing on vitamins and minerals, because it can have detrimental effects. And everything that she presents in her presentation is all evidence-based. So it's a really great session to go to, and it is every 3 months. So if you are interested in that session, again, please let me know. The other session that we have, it's called Physical Activity for Prostate Cancer Patients. Now this is an information session that is being presented by Sarah Weller, who is an exercise specialist, and she has a specialty in cancer, so she's a great person to go to, very knowledgeable, and talks about the importance of exercise and making sure that you're not just doing cardio, but you're also incorporating strength training, because both is important. And so that's, again, a session that's education session that is offered every 3 months. And what else we've added to her module is an exercise clinic. So what Sarah does now every Monday, so later in the afternoon from 12:45 to 5 p.m., she offers an exercise clinic, and she will see you in clinic and design an exercise prescription for you. So according to whatever ability you're currently doing. So if you have an exercise, don't be fearful. This is a great opportunity to be able to sit down with an exercise specialist. Sarah will take your anthropometrics like blood pressure, height, weight, calculate your BMI, ask you if there's any injuries that you've had in the past that she should be aware of, and any risk factors that you currently have. And what she'll do is she'll design an exercise prescription specifically for you. So what you would do is you would go away and do that exercise prescription either at a community gym or at home. So I do recommend going to see her. It is a service that we offer and is being paid for by the program. And Sarah will see you over the course of a year. So she'll see you initial appointment at 3 months, at 6 months, and then at a year. And she'll be doing, so she'll be taking height and weight, like I said, and she'll be seeing if there's any changes over time. And if you're not meeting your exercise prescription, she'll want to know why that is. Is it too easy? Is it too hard? She'll make it a little bit easier. So she'll amend it accordingly, okay? So the next module, Module 4, is called Recognition and Management of Treatment-Related Side Effects of Androgen Deprivation Therapy. Again, this is a preemptive education session about how hormone therapy works, who needs it, and how to reduce its side effects. The session is for both patients and partners, and the session is delivered by Nikita Ivanov, who is a nurse practitioner from the BC Cancer Agency. So he does an information session every month. It's a 90-minute information session, and he just talks about all of the possible side effects of being on hormone therapy. So there is a lot to be mindful of. Side effects include hot flashes, weight gain, some loss of muscle mass, reduced libido, erectile dysfunction, thinning of the bones, cardiovascular events. It also causes fatigue and mood, and these side effects you should be able to be aware of them so that you're able to be proactive about combating the effects. Our 5th module is pelvic floor physiotherapy for urinary incontinence. This is an information session mostly for patients who are having surgery, because we do know that you are going to experience incontinence to some degree. Again, to what degree we don't know. But we are also seeing some patients post radiation therapy as well. But for those of you who are having surgery, this is a session I would also recommend that you come before, if possible, if your schedule allows it. It's a preemptive education session which runs in parallel with our sexual side effects management program. It's given by Marcy Diane, who is a registered physiotherapist, and she's one of few physiotherapists who is certified in male pelvic floor. And so what Marcy talks about in her education session is what's happened with the bladder, why in fact you are leaking, and the importance of Kegel exercises. And she'll also give you a description of how to do the Kegel exercises, because 2 things go along with minimizing the incontinence that you are experiencing. Is one, that you're actually doing the exercises correctly, and the other is that you are doing them when you need to be doing them. So when you're bending, lifting, coughing, sneezing, pushing, pulling. And so we do expect patients to leak. It can take up to a year or longer. You do see a bit more of a change in the first 3 months. And when you're around the 12-week mark, to give me a call. And what we will offer is have you come and see Marcy in clinic, and we will cover 3 physiotherapy clinical appointments. And so you don't have to use your extended health care plan. And what Marcy will do is she will use something called biofeedback. So there's little electrodes that she puts in around the rectum area, gets you to do a pelvic floor squeeze, and it'll actually show on her monitor if you're actually doing the exercises correctly. So if you're not doing them correctly, she'll give you more direction on how to do them. So like I said, the importance is really making sure that you're doing them correctly, and then you're doing them when you should be doing. Bending, lifting, coughing, pushing, pulling. So the last module is actually our newest module. It's counseling services and group therapy workshops. We did add this about almost a little over a year ago, and we noticed that it was a really important module to implement within our program. We were seeing a lot of patients who were having difficulty with the side effects of whether, surgery or radiation therapy. And so we brought in a clinical counselor. His name is Kevin Lutz. He's here every Thursday, and he's able to see you and your partner. So if your partner wants to come in for a clinical appointment, they can come. They can come by themselves, or you can guys come together, or you can just come alone. But we do offer 6 clinical appointments for each of you that you can take advantage of. And so, if you find that you're having difficulty coping with the diagnosis, or post-operatively with the treatment, definitely give me a call, and I will schedule a clinic appointment with Kevin. What we're also doing, part of this module, is we are doing a men's group workshop. So it's called Living with Prostate Cancer, and it's been around for about a year now. We were piloting it last year in June, and we found that men really enjoyed the workshop. And so what the workshop involves, it's 3 whole day workshops, so times 3. So it's every week for 3 weeks, from 9 to 4 p.m. And you have Kevin, who's a clinical counselor, as well as with his colleague, Dr. David Kuhl, who is a medical doctor. And we take up to 6 patients per workshop. And what they do is help you, give you strategies about communication, and also come to an understanding of the change that's happened in your life, and with having a new identity, and just coping with the changes that you've been going through post-treatment. So it's a really good workshop to go to. It is, like I said, 9 to 4. We do cover the cost in terms of, if you come to the workshop, we will provide breakfast and lunch, and we will cover the cost of parking if you park downstairs. We unfortunately don't cover the time, but it is a valuable workshop to come to. It is time intensive, but I assure you that you will quite enjoy it. We've got lots of positive feedback, and it is a 3-day workshop. And the only stipulation is, one, that Kevin has seen you in clinic prior, so he knows a little bit of your history, and 2, that you're able to commit to all 3 days. So it's once a week for 3 weeks, and that you can come from the whole session, 9 to 4. So there are other treatment options available for localized disease. They do exist. They include cryosurgery, high-intensity focused ultrasound, also known as HIFU, proton beam radiation therapy. They're available. They're not available here in BC, and they're not covered by the BC Provincial Health Insurance. So if you were to go back east, they have HIFU. It is not covered. What we do know is that whether you do surgery or radiation therapy, we have enough evidence to know that these treatments work. And that's why those are the only 2 treatment options that we offer here in BC. There are other treatments that do work. There isn't enough long-term data to let us know that it's better than radiation therapy or surgery. So it's probably one of the reasons that it's not covered here. So how do we know whether treatment is working? You'll be having follow-up visits from here on post-treatment, whatever that treatment is. So if you've had surgery, you're going to be followed using your PSA level. It's hoped that once your prostate is out, your PSA level will be 0 or very close to 0 over the coming months post-surgery. If you've had radiation therapy, because you still have your prostate in there, it may not be 0, but it'll probably take about 3 months for them to figure out what an average PSA level is for you, but it would be, in the lower amounts. So what do you do if my cancer reoccurs? Some of these treatment options can be explored. So if your PSA level is rising, it does indicate that there was probably some cancer left over, or it's traveled somewhere in the body. And so you would have to look for a second line of treatment. And it all really depends on what your initial therapy treatment was. So if you've had surgery, then the options would be having salvaged external beam radiation, possibly brachy or possibly hormone therapy, also known as androgen deprivation therapy. But that is a decision that your physician would make on your behalf. So clinical trials through the Vancouver Prostate Centre and here at the PCSC program and the BC Cancer Agency, patients do have access to clinical trials for all stages of cancer. Depending on the center, it depends what trials are being offered. It is important to discuss the pros and cons of being in a trial, and also to know that you don't have to participate in being in a clinical trial. So it won't affect your care in any kind of way. Okay. So follow up with your urologist, and these are specific to the urologist here at Vancouver. So for prostatectomy robotics, Dr. Larry Goldenberg and Dr. Peter Black are the specialists for robotic surgery. Dr. Alan So is actually in the process of learning how to do robotic surgery. And the open prostatectomy is done by Dr. Galeev, Dr. So, and Dr. Black. Follow-up visits with your oncologist. For this, again, this is for the Vancouver location at the BC Cancer Agency. Brachytherapy, there is a list of oncologists here, as well as for external beam radiation therapy at the BC Cancer Agency in Vancouver. So there are further resources, and I do, recommend going to these websites just to get yourself more knowledgeable. Our website at the Vancouver Prostate Centre is a very good place to go. You'll also find our PCSC program embedded in the VPC website. The BC Cancer Agency link is there as well. And if you're looking for support groups, this link will take you to all the support groups in the Lower Mainland. So depending where you live, it'll tell you what day and what time that support group meets. So it's a good opportunity for you to be able to talk to other prostate cancer patients who either are recently diagnosed or have had treatment, and it's a good forum to be able to just get some other information about how they went through their experience with prostate cancer. And that is it. These are my contact details, so if you have any questions, you can definitely email me or call me. And if you have any questions about the presentation tonight, I'm more than happy to talk to you about that as well.